All right. For those who are just joining us, good evening and welcome for today's discussion. This is live streaming of PLAB-1 classroom discussion of air clinic. All right. So we're still in cardiovascular system, and this was where we stopped the last time yesterday. So the question on the screen is about a 56-year-old man who was recently put on antihypertensive medications and written biochemistry on 2 occasions showed sodium of 132, potassium of 7.6, and urea of 111.3, creatinine of 112. So they now ask which of the following drugs is responsible for this result: amlodipine, benflumethiazide, doxazosine, atenolol, and ramipril. So first of all, you have to interpret these results and determine the normal ranges and which one is normal and which one is abnormal. Before we proceed, let me just show you guys something. I'm sure you guys probably don't know that there's something here. It's table of normal values. All right. So if you're using the app and you get a question and you're in doubt, you don't know, you can't remember the values, just go down to the table of normal values. All right. Open it up and help yourself out. So this is serum electrolytes we are questioning. Normal sodium level is 135 to 145 millimoles per liter. Normal potassium level is 3.5 to 5.0 millimole per liter. All right. Normal urea is 2 to 7 millimole per liter. Creatinine is 55 to 120 micromole per liter. Bicarbonate is 22 to 28. Chloride is 95 to 105. So I think we should know this: 2 to 7 and this 55 to 120. So in Nigeria, most times our unit tends to be in milligram per deciliter. And if it were to be milligram per deciliter, normal urea would be like 0.6 to 1.4 milligram per deciliter. But in millimole per liter is 2 to 7. All right, 2 to 7. Then creatinine in milligram per deciliter should be like 50, less than 50 usually. So this one is now like 55 to 120 micromole per liter. So take note of that. These ones we're already familiar with these values here. Right, so we saw sodium of 132 and normal value is 135 to 145. So this one is slightly low. There's a slight hyponatremia, right? Then potassium of 7.6. This is a hyperkalemia. This is a hyperkalemia because what they give us is 3.5 to 5.0, which is normal. So this is, in fact, this is a severe hyperkalemia. Then urea of 11.3. They give us 2 to 7, right? So 11.3 is actually elevated. The creatinine of 112 is within the normal range. They give us 50 to 120, right? So what do you think will cause hyponatremia, hyperkalemia, hyperuremia? All right. Which one? Is it amlodipine, calcium channel blocker, benflumethiazide, which is a thiazide diuretic, doxazosine, which is alpha 1 and 2, alpha, is it alpha 1 or alpha 2 now? That blocker, atenolol, which is a beta blocker, and then ramipril, which is an ACE inhibitor. All right. So we have someone here who chose hyperkalemia, ramipril, ACE inhibitor. So that's the answer. Okay. Known to raise serum potassium level, also as well as ARBs. And in our previous discussions, I remember we mentioning the other side effects of ACE inhibitors, and the code is captopril, right? So there's this cough, this dry brassy cough that they have. Then A is for angioedema, all right? And P is for potassium, which is usually high potassium hyperkalemia, like we mentioned here. All right. T is for teratogenicity. So it is very much teratogenic. O is for what now? Then P is still potassium. All right. And T again is changes in taste. AC inhibitors can cause some maybe metallic taste, right? Changes in taste, taste changes. Okay. Then R is what? R is renal impairment. There's some renal impairment, all right? I and L, okay? So you just need to look at it again. Okay. This other question is about a 56-year-old man who was recently put, okay, I think it's the same question. You have a question, right? I'm listening. This how is AC inhibitor renoprotective and at the same time likely to cause renal impairment? Oh my God. This one tough. Oh. Anyway, let me start with the renal protective aspect of it, because that's the one I can defend. All right. Um, how is it renal protective? There's a way it's, let's go back to physiology or anatomy of the kidney. You know that your kidney has afferent and efferent. Like every kidney has a nephron, right? And nephron is made up of glomerulus, all right, inside the Bowman's capsule. Abi, okay. So that tuft of glomerulus has an efferent or an afferent inflow of vascular supply, all right? Then there's an outflow, which is the efferent, all right? So now, for you to increase GFR, all right, you have to increase the inflow, all right, and decrease the outflow. Okay, that's the way you increase GFR, glomerular filtration rates. Okay, so in diabetics, it's renoprotective in diabetics, so it's not like you just start giving it to everybody. It's in diabetics they're talking about. Okay, in diabetics, one of the markers of diabetic nephropathy. In fact, the earliest marker of diabetic nephropathy is proteinuria. So it's renoprotective because it's antiproteinuric. And how is it antiproteinuric? Because it contracts what does it contract now? The inflow. No, it doesn't contract. It prevents the inflow from being contracted, or rather, it prevents the outflow from being contracted, so that um, let me just demonstrate this thing. Let's look at the glomerulus. What's the Okay. You're welcome, Dr. Sochi. You're highly welcome. All right. This is your first time of joining us. So there's a button on the lower left corner of your screen. With that button, you can converse with us because you're not expected to use your microphone. In fact, the app doesn't allow you to use your microphone. It's gone. All right. So inflow, glomerulus, outflow, Bowman's capsule, proximal tubule. All right. So let's look at how it works. So the afferent is the inflow, right? Like I mentioned earlier. So it gets here, gets filtered by passing through all the layers of the renal corpuscle, all right? Then eventually produces urine, which flows down the proximal convoluted tubule, okay? So outflow, what happens in the glomerulus is filtration of blood. So inflow of blood to the afferent arteriole, all right? Flows in, filtered, and then this is where ultrafiltration, right? Ultrafiltration occurs within the renal corpuscle, that's the Bowman's capsule. Okay. Then the rest, the filtrates will flow in as urine. Then the rest of the blood will continue through the efferent arteriole. All right. So let's look at factors that affect the afferent and efferent arterioles. All right. Blood exits the glomerular capillaries by an efferent arteriole instead of a venous. All right. Because what I really want us to look at is the factors and regulation. When blood flow is reduced, that's indicating hypotension on there's decrease in sodium, blah 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 blah. They're still talking about how the I need to make a reference. Sarah, this is what you get when you ask your teacher a very tough question. You need to make reference. All right. I want us to get to the bottom of it. Let me show you my screen. I know you're not seeing what I'm doing now. I want to see. I want to see. nephrology, glomerular diseases. It's a place where they described afferent and efferent and the factors that are controlling them. That should be in the anatomy section. This is not the original. Yep, this is the correct book. So here they are talking about determinants of renal function, blah blah blah. Well, it seems I have to get back to you on this question. I'll look at it myself later, then get back to you. No, I've looked at it before, but this particular instance, but what I'm actually trying to do is not just to answer your question, but I want to give you the pathogenesis, the pathology, like what happens in the renal tube that made us say that it's contributing to filtration, right? Okay, we are back. So a 50-year-old man who is hypertensive recently underwent a change in medication. 2 days later, he developed wheezing. Which drug can cause this? Change in medication, 56, and he's hypertensive. So it means they gave him an antihypertensive. They changed his antihypertensive medications and he develops wheezing. We just mentioned it a few minutes ago. So which of the drugs can cause a person to develop wheezing? Hmm, apparently, apparently, it is not Ramipre. It didn't talk about cough anyway. So I guess wheezing, like wheezing implies asthma. So atenolol, yeah, Sochi, atenolol, okay? Because one of the side effects of beta blockers is that there's this A, B, C, D, E side effects of beta blockers or conditions where you have to avoid beta blockers. One is asthma, and B is what? Um, anyway, I'll skip B for now. C is heart failure, all right? In postgraduate level, you can use beta blockers, but you're not to use it when in the acute phase, all right? So generally, you avoid beta blockers in heart failure. So A is asthma, B is something, I'll find it. Then D is diabetes, right? So these are some of the conditions. Even emphysema, COPDs, asthma, now they can be worsened by beta blockers, all right? Conditions. Asthma, see now, asthma, COPD, other lung disease, diabetes, low blood pressure. So maybe we'll just say B is blood pressure. That's low blood pressure. All right. Then serious blood conditions such as renal phenomenon. Then congestive heart failure, severe congestive heart failure, that's CCF. Then severe peripheral arterial disease, renal phenomenon is related to that one. Metabolic acidosis. All right. So I think that makes a lot of sense from what I've said. So it's A, B, C, D, E. What about the improvement in mortality by some beta blocker in heart failure? Um, well, that it has some benefits in improvement of mortality does not mean you just carry beta blocker and go and knock a patient. Fine, it's good. That's why I said it's postgraduate level. All right. At your level, have you finished using spironolactone, frutamide, which other drugs we use? You can even use AC inhibitors, ramipril or ARBs, angiotensin converting enzyme, failure. but it improves mobility, improves the function of the patient, improves the life, the quality of life. All right. So similar thing. Beta blockers, some of them, like the ones that are cardioselective. All right. So even if you want to use beta blockers in heart failure, it has to be the cardioselective ones. So the commonly used one, especially when there's an associated something else, not just straightforward heart failure. Especially when there's an associated maybe myocardial infarction. Those are where beta blockers come in and play a very vital role. Right, then arrhythmias as well, atrial fibrillation, those are where beta blockers come in and play a very important role. So the next question is, a 57-year-old man having hypertension on oral antihypertensives, however, he's finding it difficult to mobilize as he feels dizzy whenever he tries to get up. All right, feels dizzy. So that's postural hypotension or postural dizziness, and he's already on an oral antihypertensive. What is the most appropriate investigation for him? Ambulatory blood pressure, ECG, MRI, chest X-ray, CT scan. What do you think, guys? Ambulatory BP. Sochi, you didn't attempt this question. I should just write down. All right, Dr. Kara is correct. Ambulatory blood pressure, because the keyword in PLAB exams, what you have to look out for. Are you not hearing me? You know, one thing about this platform is that once you are on it, all right, it tends to attract the network that you need in it. So far you can hear me. Network will not stop you from posting your comments or looking at or seeing what is on the screen. All right. Like so far once you can hear me, that's the litmus test that you can see every other thing that is happening. So ambulatory BP. So like I was saying, in PLAB-1 exam, the first thing to look out for is the clincher, called the clincher. Let me spell it for you. Lincher. All right, clincher. And what that means is the giveaway. All right, the tip. Every question has like a tip, something that tells you or that implies the answer. So the thing that implies the answer here, first, the patient is a hypertensive. All right, but what implies the answer here is that he feels dizzy when he tries to get up. And this singular statement is also known as postural hypotension, right, or postural dizziness. So when a patient is having something like this, you have to do what we call the ambulatory blood pressure monitoring, ABPM, ambulatory blood pressure monitoring. So you check the blood pressure, both supine and erect, and compare. All right. So that's when you now see a difference. In fact, postural hypotension has a definition. So when you have a drop in the blood pressure by more than or equal to 20 millimeter of mercury systolic or 10 millimeter of mercury diastolic on change of position from supine to erect. All right, that's how you define postural hypotension. All right, so doing your ambulatory blood pressure monitoring will help more than even your ECG at this point, because symptom is what directs you to what you're going to do next. So move. 7-year-old woman who is suffering from hypertension presented to the hospital with complaints of recurrent falls when trying to get out of bed or getting up from sitting. This one, we're still talking about postural dizziness again. She is on some antihypertensive therapy with no other medical problems. What is the cause of her fall? So the question now is, which she's suffering from? She's hypertensive, she's 7. She came to the hospital because she's having recurrence. Recurrence means like it happens all the time. Current falls when trying to get out of bed or getting up from sitting. So this is postural dizziness, definitely. When she's lying down, she's fine. But immediately she tries to get out of bed, like she tries to ambulate, right? She falls. So which of these drugs can cause postural hypertension? Calcium channel blockers, vertebropelvic insufficiency, thiazide diuretics, hypoglycemia, infection. Dr. Noya, you're welcome. Dr. Sochi, I want to believe you figured out your network. Welcome back. Dr. Noya, the question on board, give us your answer. Dr. Kara thinks it's calcium channel blockers. So Noya, give us your own answer. Sochi, drop your own answer. Let's compare and contrast. Do you agree with Kara? Do you think it's calcium channel blockers? It's actually a given that most antihypertensive medications can cause postural hypotension, but some are more notorious for that more than others, right? So there's so many of all these diagnoses that you should ignore because they've already told you no other medical problems. So the only thing she has is systemic hypertension with no other medical problems. So there are some things you should already ignore, like all these vertebropelvic insufficiency, infection, hypoglycemia, all those ones you should ignore them. So it's between this and this. I'll go with Chara. So Dr. Dr. Kara, come and defend your answer. Welcome, Noya. Good evening. So the key is thiazide causes postural hypotension by volume depletion. But many antihypertensives, frankly, can cause postural hypotension. All right. So it could really have been this. The thiazide. I think one thing that stood out was the fact that it was recurrent falls. Okay. Let's go. A 58-year-old man suddenly becomes shocked several days after suffering an acute myocardial infarction an acute anterior myocardial infarction. His chest X-ray shows a large globular-shaped heart and clear lung fields. What is the single most likely explanation for the abnormal investigation? So the abnormal investigation I'm talking about is chest X-ray, which shows a large globular-shaped heart. Shocked. What they mean by shock? Maybe cardiogenic shock. Patient is in shock. Hypotension, tachycardia, that kind of shock. Right? Several days after suffering an acute myocardial infarction. The chest X-ray shows a large globular-shaped heart. There's cardiomegaly. So what is the explanation? Acute pericarditis, cardiac tamponade, atrial thrombus, left ventricular aneurysm, Dressler syndrome. Several days. Left ventricular aneurysm, atrial thrombus, cardiac tamponade, acute pericarditis. So the clincher is actually the large globular-shaped heart, which follows myocardial infarction. So many of these things they are mentioning are complications of myocardial infarction, like acute pericarditis, possible complication, cardiac tamponade, I don't know, atrial thrombus, left ventricular aneurysm, Dressler syndrome. Dressler syndrome takes a while, but they're just talking about days, several days. Dressler syndrome, like 2 to 6 weeks. Okay. So which of you should I go with? Dressler. Sochi thinks it's Dressler syndrome. Noya thinks it's acute pericarditis. Sarah thinks it's aneurysm. Let me go with what I think. Necessary shows a large globular-shaped heart. Will acute pericarditis cause a large globular-shaped heart? I doubt. It will not show like that on chest X-ray. Will Dressler syndrome appear as a large globular? You know that Dressler syndrome is actually chronic pericarditis. So it appears as a large globular-shaped heart. So see the things that can appear as globular-shaped heart. Maybe cardiac tamponade can appear as large globular-shaped heart, and then left ventricular aneurysm can also appear that way, I think. So, guys, we are all filling this question together. It's between this and this, I think. So it's cardiac tamponade. Chest X-ray. You know, see how big, see how big this thing looks. Right? Because it's logical. all of those large sampling. Probably think of like this should be blood. This is likely to be blood. So look at it. Very big heart, almost covering the entire chest. This person has a very large heart. He will not have anything to give. His cardiac tamponade. Shock in post-myocardial infarction with globular heart on chest X-ray and clear lung field. So if you see a 58-year-old man, 58-year-old with type 1 diabetes mellitus on antihypertensive therapy for 13 years, developed central chest pain for 45 minutes while driving, associated with cold sweating and dyspnea. What is the single most appropriate diagnosis? 8-year-old, type 1 DM, type 1, wow, on antihypertensive therapy. So diabetic and hypertensive for over 30 years, central chest pain for 45 minutes while driving, associated with cold, sweating, and dyspnea. Single most appropriate diagnosis: pericarditis, pulmonary embolism, myocardial infarction, costochondritis, pneumothorax. Right, he was driving. So will you consider driving a relaxing activity or a stressful activity? Because that's what will differentiate these two: pulmonary embolism versus myocardial infarction. Is driving a relaxing activity or is driving a strenuous activity or a stressful activity? Then also look at the associations: cold sweating, that's diaphoresis, and then dyspnea. So it's between pulmonary embolism and myocardial infarction. Tonoya said myocardial infarction. Yeah, correct. Driving is a sort of stressful activity. Yes, it's a stressful activity. So it's myocardial infarction. In pericarditis, pain is aggravated by inspiration or lying flat and relieved by leaning forward. I remember we've talked about this before. Pericardial rub may be present and there may be fever. In pneumothorax, pain is not central but pleuritic. Yes, celebrate too. You got this one. Pulmonary embolism is dyspnea and pleuritic chest pain. All right. In costochondritis, localized pain or tenderness at the costochondral junction, enhanced by motion, coughing, or sneezing. The given picture of central chest pain for 45 minutes, more than 30 minutes, sweating and dyspnea with major risk factor of DM and hypertension suggests the diagnosis of myocardial infarction. So, pulmonary embolism, dyspnea, and pleuritic chest pain. I think that's what you need to take note of. And pulmonary embolism tends to occur on why doing something that is sedentary, like sedentary activities, because usually it follows a deep venous thrombosis, right? So the person must have been living a sedentary lifestyle, maybe on a long hour flight, something like that. As soon as he gets up, now shows an embolus, which eventually becomes a pulmonary embolus, causes coughing, dyspnea, difficulty in breathing, sweating, diaphoresis as well can occur with pulmonary embolism, and sometimes they have hemoptysis. All right, and the pain is pleuritic, unlike myocardial infarction that is not expected to be pleuritic. Also, pain of pericarditis is also pleuritic and is worsened by lying flat and relieved by leaning forward. And costochondritis is localized to the costochondral junction, all right, enhanced by motion, coughing, or sneezing. So MI is pain more than 30 minutes, most likely MI. All right, a 59-year-old patient has been diagnosed with hypertension. His blood pressure has been more than 160/90 on 3 separate occasions. His biochemical profile is as follows: sodium 145, which is normal, potassium of 6.2, elevated, creatinine of 112, urea of 5.7. Okay, so what is the most appropriate antihypertensive drug for him? With this potassium, which antihypertensive drug will you give him? Is it amlodipine, benzoyl-flumethiazide, ramipril, losartan, propranolol? So she said thiazide. No, yeah, what do you think? Benzoyl-flumethiazide. So, Cara, what do you think? Cara, you're missing in action. All right. So you guys are correct. Yes, it causes hypokalemia, hyponatremia, hypomagnesemia. However, it causes hyperglycemia, what's the other one? Hypercalcemia, hyperuricemia, and hyperlipidemia, right? Hyper. 60-year-old diabetic complains of pain in the thigh and gluteal region on walking up the stairs for the last 6 months. Pain on the thigh and gluteal region on walking up the stairs for the last 6 months. He is a heavy smoker and has ischemic heart disease. What is the most appropriate diagnosis? Thromboangiitis obliterans, sciatica, deep venous thrombosis, atherosclerosis, embolism. Yeah, I like some things, right? Pain on the thigh and gluteal region on walking up the stairs for the last 6 months. This is the clincher. The clincher here. Heavy smoker and also has ischemic heart disease, hypertension, diabetes. Remember, she's also diabetic. Atherosclerosis. Her age. Her age. Her age is a big factor. If she was younger, all right, could have been thromboangiitis obliterans, but because she's older, she's at risk of atherosclerosis. All right. Then combined with all these other risk factors, smoking, diabetes, ischemic heart disease, right? So atherosclerosis. And ischemic heart disease is also seen in people that have atherosclerosis as well. So apart from, so it implies that what she has is actually peripheral vascular disease. There's no redness, itching, or rash, no ulceration of the skin. All right. You guys can't hear me. Can't hear me. You can hear me now. So we move. All right. A 60-year-old is on treatment for ischemic heart disease, hypertension, and hyperlipidemia. During the night, he complains of wheezing and shortness of breath. Which of the following medications is responsible for that? 60-year-old, treatment for ischemic heart disease, hypertension, and hyperlipidemia. Complains of wheezing and shortness of breath. Which drug has that side effect? Amlodipine, atenolol, ramipril, simvastatin, benzoylflumethiazide. Dr. Noya joined us after we discussed this question. He thinks it's ramipril, causing wheezing in the night. And this question has already told, in fact, what's the diagnosis, first of all? In the night, you are having wheeze and shortness of breath. That's asthma. Yes. Dr. Noya, you've missed one step now. Now you cannot get the step two. It's atenolol, right? We mentioned that beta blockers wasn't A, B, C, D, E. Beta blockers wasn't asthma. Beta blockers wasn't, what's B again? Beta blockers wasn't congestive cardiac failure, that's C. Beta blockers wasn't diabetes mellitus, that is D. There wasn't emphysema. Okay. What did I say was B again? Anyway, so a 60-year-old lady has severe chest pain. ECG shows, that was not what I said. Okay, I get. A 60-year-old lady, of course, bronchodilation is, yes, follows, yeah, beta agonists like salbutamol, salmeterol, all those things, right? They are all beta agonists. Two specifically, beta 2 agonists. But beta blockers, because they are non-specific, so the ones that are likely to worsen this thing will be the non-specific ones. Propranolol, many of these ones we use atenolol, okay, they are non-specific. So because they block both beta 1 and beta 2. We know that beta 1 is found in the blood vessels. Beta 2 is found in the bronchus, right? Bronchial muscles. So when you block those things, you now begin to have bronchoconstriction. So a 60-year-old lady has severe 60-year-old lady has severe chest pain. ECG shows changes of inferior wall myocardial infarction. ECG also shows progressive prolongation of PR interval until a QRS complex is dropped. What is the most probable diagnosis? This one is, they've given you the answer now. Progressive prolongation of PR interval until QRS is dropped. What's this thing called? What's this phenomenon? There's a phenomenon it's named after. Wekenbeck phenomenon. When care. I'll give you the answer, but I just want us to learn. Mobius type 1 and second degree heart block, Mobius type 1. That's where you have that Wekenbeck phenomenon. No, after I've given the answer, that's when you're answering. But clap for yourself, sir. Progressive prolongation of PR interval culminating in non-conducted P wave. Like, keep prolonging the PR interval until you now skip P wave. See, PR, this P wave, this QRS, this PR interval, okay, this T wave. You can see that this PR interval here is longer than this one. Let's look at the next one. This one is longer than this one. This one is longer than this one. Then this one just has only P wave, no QRS. Okay, so it has skipped one. It now starts again. Same wahala. So it is Mobius type 1. So let's see other features of second degree Mobius type 1. The PP interval remains definitely constant. That's interval between the P waves, because there's always a P wave. It's just the QRS complex that is discarded one point or the other. Okay, but the PR interval keeps elongating. The greatest increase in PR interval duration is typically between the first and second beats of the cycle. The RR interval progressively shortens. So as PR interval is elongating, the RR interval is shortening progressively with each beat of the cycle. The Wekenbeck pattern tends to repeat in PQRS groups with ratios of 3:2, 4:3, 5:4. We've seen the ECG. I want to see the Wekenbeck type 2 or Mobius type 2. Wekenbeck. Oh. So AV nodal block is a type of heart block that occurs when the electrical signal traveling from the atria, right, to the ventricles. That's why you call it AV nodal block. It's an obstruction in the impulse from the atrium to the ventricle. All right. So we are looking at the types. We want to find the types. Impulses generated from the SA node, right, travel through the atrium to the AV node. AV node is in the interventricular diatrial septum, all right, somewhere here. From the SA node somewhere here, the AV node, right? Then from there, it travels along the two right and left bundle branches. Then it gets here, now travels through the Purkinje fibers, eventually to the ventricles. So the first degree, there are three types of AV block, right? One is a first degree AV block, there's a second degree, and then there's a third degree. The third degree being the most severe. So we normally differentiate the different types of AV block on ECG. So the first degree atrioventricular block occurs when there is a delay but not disruption as the electrical signal moves between the atrium and ventricle. And like we said, is not as severe as the third degree. Okay. So additionally, there are no dropped or fixed beats. So let's look at first degree P wave, QRS, T wave, another P wave, QRS, T wave. Okay, so it means you can see there's a prolonged PR interval here. It's more than 5 small boxes. Normal PR interval is supposed to be 3 to 5. This one is like 6, almost going to 7, right? So, but it's constant. It's constant. It's constant. It's constant. That's first degree AV block, right? So the second degree AV block now has two types. There's second degree type 1, also known as Mobius type 1. And it is the Mobius type 1 that exhibits that Weckenberg phenomenon, whereby the PR interval progressively gets longer. This one is longer than this one until eventually it skips the QRS complex. You have a P wave and there's no corresponding QRS complex. And remember what they say, that as the PR interval is prolonging, the RR interval is shortening progressively. Like this one now is a 2-in-1, a 2-in-1 block. Like after 1, 2, a 3-in-2 block. All right. So let's go to the second degree type, Mobius type 2, second degree type 2, also known as the Mobius type 2. In that one, PR, 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 let's see what happens. Mobius type 1 is characterized by a progressive yet reversible block of the AV node. On ECG, this is defined by a progressive prolongation of PR interval resulting drop. PR interval gets longer and longer until the beat finally dropped or skipped. Some patients are asymptomatic. Those who have symptoms respond to treatment effectively. There is low risk of Mobius type 1 leading to heart attack and complete heart block. I think type 3 is complete heart block. Mobius type 2 is seen by a sudden, it's caused by a sudden, unexpected failure of the his Purkinje cells to conduct the electrical impulse. On ECG, the PR interval is unchanged from beat to beat, but there is a sudden failure to conduct the signal to the ventricle and a resulting random skipped beat. The risks and possible effects of Mobius type 2 are much more severe than Mobius type 1 in that it can lead to severe heart attack. You guys following? I'm not talking to myself. Are you following? So, second degree heart, we see that the PR interval is relatively constant. All right. It's the same here. It's the same here. It's the same here. But suddenly, there's now a skipped beat. That's what you call the second degree Mobius type 2 heart block. Okay. Then the third degree AV block with junctional escape. Let's look at third degree. Third degree AV block occurs when the signal between the atrium and ventricle is completely blocked. So it's actually a third degree that is called complete heart block. So it means that the P wave and the QRS are just different. They will no more be coordinating. So none of the signals from the upper chambers make it to the lower chambers. On ECG, there is no relationship between P waves and QRS complexes, meaning the P waves and QRS complexes are not in a ratio of 1:1. Third degree heart block is the most severe of the AV blocks. Person suffering complete heart block needs emergency treatment, including but not limited to insertion of pacemaker. So third degree heart block. Here, see P wave. See the white space between it and QRS complex. See, just everything just they go anyhow. See, see. All right. So I think we've done justice to AV blocks. There's the management we want to look at. Patients with first degree heart block do not have any resulting severe or life-threatening symptoms, such as symptomatic bradycardia, or of course we know where the issue really is when you get to the complete heart block. So most times people with first degree heart AV nodal block, you don't do anything, it's just conservative management, watchful waiting. Second degree type 1, second degree Mobius type 1, which is the Wekenbeck phenomenon, you may want to, some of them you also manage conservatively, just watch and wait. But sometimes you may now need a transcutaneous pacing or transvenous pacing. And they also respond well to atropine. Okay. Then Mobius type 2, second degree heart block, Mobius type 2, and third degree heart block are much more likely to have symptomatic bradycardia and hemodynamic instability, such as hypotension. Right? So it means you must treat, you must do something. You cannot manage conservatively. Additionally, there is an increased risk of patients with Mobius type 2 heart block developing third degree heart block. Therefore, these patients often require temporary pacing with transcutaneous or transvenous pacing wires, and many will ultimately require a permanent implanted pacemaker. If the heart block is found to be caused by irreversible conditions such as Lyme's disease, the underlying cause should first be treated. Often this will lead to resolution of the heart block and the treated symptoms. So pacemaker, permanent pacemaker is the treatment of choice for is a second degree type 2 or third degree, which is a complete heart block. So we've done justice. So our answer is Mobius type 1. Mobius type 2, 1, right? Second degree heart block with Mobius type 1. Then inferior MI is frequently associated with conduction defect. Can we think of any reasons why inferior MI is frequently associated with conduction defects? Does it have to do with the fact that AV node is actually relatively posterior? All right, move. I'm seeing that I've streamed for 1 hour plus, almost 1 hour, 30 minutes. It shows changes of inferior wall MI. ECG also shows progressive prolongation of PR interval, the QRS complex is dropped. Why are they making this thing so cheap for this people? It's so cheap. Give you the same question. All right. What is the most probable diagnosis? The repeat, I think, right? The repeated question. Do you want to attempt it or do you want to answer? I should just skip it. Okay, here we come with another one. 60-year-old lady who had stroke 3 years ago now reports having increased dyspnea on exertion and atrial fibrillation. Chest X-ray shows straight left cardiac border on the cardiac seal holes. What is the most probable diagnosis? This thing is characteristic. When there's straightening of the left cardiac border, it's called mitralization. Left cardiac border. Mitralization of the left cardiac border. What is your diagnosis, guys? 60-year-old lady. She had stroke 3 years ago. Now she's having dyspnea on exertion and atrial fibrillation. All these things could be related. The stroke and the valvular condition, they are all related. So I don't think you guys have an idea about this question. Something called mitralization of left cardiac border. You know, normally the left cardiac border is supposed to be slanted this way. No, yeah, you're guessing. All right. So it's supposed to be slanted this way. But in this condition, it now becomes straight. All right. Sarah, you're guessing. All right. So, so there's straightening of the left cardiac border. All right. So what do you think would cause straightening of that left cardiac border? It means that the left atrium is enlarged. All right. So it's only the left atrium that will be enlarged that will now make that left cardiac border to be prominently, to now become straight instead of being slanted like this. Now becomes straight. So it means something is occupying space here. So I think it's atrial hypertrophy, left atrial hypertrophy. And what among all these things now can cause left atrial hypertrophy? Means first of all, it has to be a mitral valve disease. So you guys are not too far-fetched anyway. Ischemic mitral regurgitation, mitral valve prolapse, rheumatic mitral valve stenosis. So all of you have chosen different things. All right. And of course, it's not pulmonary. We're not even talking about the pulmonary side. We're talking about the left side of the heart. So to me, I think what to cause the left atrial enlargement is a mitral stenosis. But let's look at it. Of left heart border in chest X-ray because of increased prominence of the convexity formed by the main pulmonary artery. and east left main branch of the left atrial appendage. What are you talking about? Just give me the diagnosis now. Yes, left atrial enlargement. All right. I guess we'll have most. Anyway, likely it's going to be mitral stenosis that will cause left atrial enlargement. Taking time to load. Clap for yourself, Sochi. You just clap for yourself half because you are guessing to, you are putting query. This one puts query, this one puts query. Oh yeah. So rheumatic mitral valve stenosis, points in favor, dyspnea on exertion, straight left border. In fact, this is the main point in favor. Every other thing can have dyspnea on exertion, right? So straight left cardiac border, that's classical for what you call mitralization of left cardiac border. That's seen in left atrial enlargement. And the only thing among the options that can cause a left atrial enlargement is mitral stenosis. All right? Because obviously you're closing that portal, you're obstructing it. So when you're overusing something, it will get large. When you need more force to overcome pressure at the mitral opening. Atrial fibrillation is a common association. Yeah. Finally, we're in 47%. A 60-year-old man has had spontaneous painful swelling of his right knee for 3 days. 5 days ago, he had an inguinal hernia repaired as a day case. He takes bendroflumethiazide 2.5 milligram daily. Rheumatic now. Rheumatic is rheumatic. They have to come from anywhere. Like following a rheumatic fever. That's what it means. So it means that this patient must have had rheumatic fever as a young person. This woman, likely, if you go and take a history, she must have had rheumatic fever when she was young. So years later, she's now having rheumatic heart disease. And she's commonest valve that rheumatic heart disease affects is the mitral. I think that was also something they were using to tell you that is likely mitral, because commonest valve affected by rheumatic is mitral valve. All right. So a 60-year-old man had spontaneous painful swelling of his right knee for 3 days. 5 days ago, he had an inguinal hernia repaired as a day case. He takes this 2.5 milligram daily. He is apyrexia, like he doesn't have fever. What is the single most appropriate diagnostic investigation? Blood culture, C-reactive protein, D-dimer, test X-ray, serum uric acid. Of course, it does. It has a link. Embolism. When a patient has rheumatic heart disease, patient has murmurs, has vascular stasis, blood stasis in the heart. The person is at risk of showing an embolus. That's why they are, when you hear a patient that has heart disease, ischemic heart disease, rheumatic heart disease, heart failure, you always place them on anticoagulants, even atrial fibrillation. All right. And the patient also has atrial fibrillation. That atrial fibrillation itself can cause embolism because there's, the factors that cause thrombus formation, that enhance thrombus formation. I think SHE, stasis, hypercoagulability, and endothelial damage. These three factors are known to be associated with thrombus formation, right? So thromboembolic phenomena. We have stasis. Anytime the blood flow is slow, there's likely going to be coagulation. And when there is that coagulation, eventually that's thrombosis, right? Eventually part of it will break out and go to a distant tissue. That's what you call embolism. And because the lesion is on the left side of the heart, once it embolizes, it will go straight into the aorta. And you know that the aorta is the blood supply to the entire system. From the aorta, arc of the aorta, you have supply to the brain, carotid, so the person can have a stroke. From that same arc of the aorta, you have supply to the lower limbs, the person can have peripheral vascular disease. All right? It's embolism. That's the link. So back to the question here. 60-year-old man, spontaneous painful swelling of his right knee for 3 days. Spontaneous. 5 days ago, he had an inguinal herniorrhaphy. All right. He takes this for 5 milligrams daily. Doesn't have fever. So what is the single most accurate diagnostic investigation? Blood culture, C-reactive protein, D-dimer, chest X-ray of the what's chest X-ray of the knee? Serum uric acid. I didn't realize we entered hematology. What's the relationship? Painful swelling of his right knee. It's the knee, it's not scalp. Talking about D-dimer, Dr. Para. Serum uric acid. What are you thinking about? What are you thinking about, Dr. Sochi? That's making you think it's serum uric acid. That will be the diagnostic investigation. So this is a sudden onset, painful swelling of the right knee for 3 days. He had a surgical operation. You could be right anyway. Dr. Kara, I mean, because he had an operation 5 days ago, like something that made him to stay in one place, like surgery. He takes this daily. He doesn't have fever. This he doesn't have fever helps us to rule out septic arthritis. So it's not blood culture. It's not C-reactive protein because it's not infective. From this, he doesn't have fever. He's hyperexia. He has surgery and he's hypertensive. Yeah, you may be right. But what will be your diagnosis that will make you right? Because we're talking about knee swelling, not calf. Or have you changed your answer? Change the answer to knee X-ray. Dr. Noya said it's uric acid. You and Sochi. So which diagnosis are you thinking about that is making you think it's serum uric acid that will be diagnostic? Will you just go and do serum uric acid for everybody? Uric acid nephropathy from the thiazide. Yeah, you may be right. But I know that this drug has to be contributory to this question. They can't give you this information without it being contributory. Uric acid nephropathy from thiazide. Because thiazide can cause hyperuricemia. And hyperuricemia can present with sudden onset. That's like gout. Abi, that's gout now. But gout usually presents with tophi in the big toe. This one is the knee. Anyway, see the answer now. You guys are correct. Serum uric acid. Diuretic causes hyperuricemia, which can precipitate an acute attack of gout. Let me clap for you. You did well. A 60-year-old, okay, final question for today. 60-year-old patient who has had a myocardial infarction a week back presents with dyspnea and pericardial rub. ECG shows ST elevation, chest X-ray, loss of margin, and the costovertebral angle. What is the single most likely cause? Cardiac tamponade, mitral regurgitation, Dressler syndrome, atrial fibrillation, emboli. 60-year-old had MI a week ago and has dyspnea, pericardial rub, pericardial friction rub. It's classical for something now. They also still have ST segment elevation. Chest X-ray shows lots of margin at the costovertebral angle. So they're losing the costovertebral angle. This is straightforward. What do you guys think, guys? Like Dressler, like you like dresses, like to dress up, keep dressing, like to dress wounds, hairdresser. All right, but you're correct this time around. It's just the friction rub that gave it away, right? But the one that was a little bit confusing was he said 1 week back, and we know that Dressler syndrome was like 2 to 3 weeks, 2 to 6 weeks following a myocardial infarction. So, but there was overwhelming evidence for it because of the pericardial friction rub. No other thing here can cause pericardial friction rub. The only cardiac tamponade that comes close, but they didn't give us anything that suggests cardiac tamponade. Cardiac tamponade, we having hypotension, a lot of things, distended neck veins, right? Generally, hemodynamic instability, tachycardia, hypotension, distended neck veins, very important, but lack of wide descent, some other things too. All right. So, in the absence of any questions, we are going to call it a day at this point. Cover 10% today. So tomorrow we hope to hit 58%, right? So that before the end of this week, we are done with cardiovascular system. Do you have any questions? Is there anything you want us to clear up concerning cardio? Any questions, guys? No questions. It's assumed that you understood everything. Should I ask you my own question? What will I ask you now? You know, in the United Kingdom, they have a lot of their patients have myocardial infarction, right? So, including heart failure, is all linked to myocardial infarction based on their diet. I don't know, the diet, their genetics. They are more predisposed to coronary artery disease. But down here, we are more predisposed to systemic hypertension, essential hypertension. All right. So, but there is now beginning to be a change because in relation to classes, right? So the affluent class, the wealthy class, tend to now start coming down with myocardial infarction. They can afford it. So they are eating Western food, so they are getting Western disease. But the middle class and the poor are still having systemic hypertension, right? So the question I will leave you with is on atrial fibrillation. How do you manage atrial fibrillation? How is your take-home assignment? All right. How do you manage atrial fibrillation? So go and read it. It's a very important topic. All right, guys. Thank you for coming around and see you tomorrow. At which point we shall continue. Continue like this. Now go to smash this thing. Now go just to smash the thing. I'm ending my live stream. Thank you for coming.